Good afternoon, everybody. Today we're going to start in on the hematology. It's afternoon here anyway at this time. I've got 3 that I'm going to dictate for you, and then there is a 4th PowerPoint that is more of a question and answer, kind of help you test yourself. So if you'll bear with me, we'll get started on this one. I have integrated both the pediatric and the adult together in these, but when it comes to testing, you will be going by the values that are in your med-surg book, okay? So, I am not going to go over the A and P with you extensively. That's in the first portion of the chapter, and if you would please just look it over. You should have your A&P down from A&P 1 and 2. Bone marrow is responsible for the production of your red blood cells, white blood cells, and platelets. And later on this semester, you're going to be studying about the immune responses with me and with Miss Candler. Okay? It is present. Bone marrow is present in the flat bones and the ends of the long bones, but with aging it's going to be replaced with fatty tissue, so you need to take that in consideration when you're working with older adults. The stem cells are the precursor cells to all cells because they're capable of becoming any type of cell depending on what the body needs at the time and the specific growth factors and cytokines that are present. Okay. Blood components, you're going to see albumin, globulin, and fibrinogen. Albumin maintains the osmotic pressure in your blood. Globulin is going to transport the system and protect it from infections. Your fibrinogen is active for fibrin, which is critical in your clotting process that we are going to learn about later on in this chapter, okay? Let's talk about your erythrocytes. Red blood cells are your largest portion of your blood cells. They are biconcave or disc-shaped. They can change their shape without breaking, and the amount that a person has is going to vary with your gender, your age, and your general health. Lifespan of a red blood cell is 120 days. The old cells are trapped and destroyed in the spleen and the liver. Okay, when the cell is destroyed, the heme is released and it's recycled, and that is also stored in the liver. Each hemoglobin molecule needs iron to transport up to 4 molecules of oxygen. So iron is a very essential part of your hemoglobin. Hemoglobin also carries your carbon dioxide to help maintain your acid-base balance, which you will learn about later on with Miss Candler. The total number of red blood cells needs to be monitored and regulated to ensure that your patient's got enough present for good tissue perfusion, but not so many present that clotting becomes a problem with these patients. Let's think about this for a minute. So the more oxygen the tissue needs, the greater the production of red blood cells in the body to answer that oxygen demand you're going to see. When tissue oxygen demand is not met, then you're going to see a resulting hypoxia, which prompts your kidneys to produce erythropoietin. And when erythropoietin is increased, it produces more red blood cells. So the tissue oxygen demand is low, then the kidneys are going to stop your erythropoietin, and the red blood cell production is going to decrease, okay? Substances needed to perform hemoglobin and red blood cells, needed in the formation of hemoglobin and red blood cells are your iron, your B12, folic acid, copper, pyroxidine, cobalt, and nickel. A lack of any of these can result in anemia. Okay? Now your leukocytes, white blood cells, we're going to go into this more in detail in another one, but just to hit on them real quickly in your A and P chapter. White blood cells are also formed in the bone marrow. They work to protect the patient through inflammation and immunity. Like I said, you're also going to study this later on in the semester in your immunology. But you need to know the table in your med surg book on table 39.1 on page 787. Okay, it gives you your values of these. Basophils, what are they? They have an important role in your allergic reactions. Elevated percentage can indicate an inflammatory condition is going on in the body. Your neutrophils are responsible for maintaining normal host defense against pathogens in response to any invading organism in your body. They reach the site quickly, but they have a very small number. The eosinophils, what they do is liberate heparin and histamine and serotonin in allergic reactions, and they intensify this inflammatory response. Increasing the numbers may indicate a parasitic infection in the body if they have an increased number of eosinophils. Okay? Your monocytes are macrophages. They engulf and digest microbes and foreign substances. They migrate to the tissue and mature into macrophages, which are the scavengers that are activated when your membranes come into contact with that antigen, and these other white blood cells will activate them. They have a lifespan of 2 to 4 months. And like I said, they live outside of the blood system in other tissues as well. And then you have thrombocytes, or your platelets. As you can see, they live 5 to 9 days. You can have 150 to 400,000. Platelets are the smallest type of blood cells formed in the marrow. The platelets stick together in an injured blood vessel, creating a fibrin plug or a scab. And they are very important for helping small blood vessels stay intact and helping repair large ones after they're damaged. They're stored in the spleen, and they are controlled by thrombopoietin growth hormones. Okay? Now let's talk about some of the accessory organs that help in the blood formation. Your lymphatic system. B cells are released as immature cells into the bloodstream and interact with antigens and protein to become activated to produce antibodies and immunoglobulins. This is the humoral immune response, and like I said, we're going to learn about this a lot later on, a lot more later on anyway. The main function of these organs is to collect and return interstitial fluids, and thus to help maintain your fluid balance. The lymphatic system defends the body against diseases by producing lymphocytes. They absorb lipid from the intestine and transport them into the blood. They function as a filter or a reservoir, acting as an incubator for these white blood cells. T cells mature in the thymus gland and function in the peripheral tissue to produce cell-mediated immunity and antibody production. Both your B cells and your T cells produce memory cells that attack disease-causing organisms if there's any subsequent invasions after the first one. The second response is much quicker than your first response will be. Okay? The spleen, it stores approximately 20 to 40 milliliters of red blood cells. It removes old blood cells, it filters and destroys antigens before they can enter the systemic circulation, and catalyzes the hemoglobin released from decaying erythrocytes and returns that iron component back to the bone marrow. The spleen will store 1/3 of the total volume of platelets. A patient with hematologic disorders that result in higher turnover of erythrocytes present with an enlarged spleen. Okay? Excuse me. The liver produces bile. It metabolizes hormones and drugs. It synthesizes proteins and glucose and blood clotting factors and stores vitamins and minerals. It also changes ammonia. It converts fatty acid to ketones. It produces coagulation factors that are necessary for that fibrin clot formation. And it produces anticoagulants so that there's not too much clotting going on in the patient. Okay? Hemostasis, it is a complex function of balancing blood clotting action with anti-clotting action. Okay? The balance between the force that causes blood to solidify or to remain fluid is very delicate and involves several interacting systems. Now, your primary is defined as stopping the blood flow. Primary hemostasis is vascular contraction. Okay, so your vessels contract, the platelets will adhere to that contracted vessel, and it'll form a soft aggregate plug. Okay, after the injury, you're going to see a temporary response of that vasoconstriction. It's going to slow that blood flow down in order to enhance the platelets to be able to adhere to it and to activate. Okay, this is a very short-lived response. In that immediate vasoconstriction can stop pretty quickly. The initial platelets will stick together at the wound site, releasing ADP, which also aggregates to form a plug. Then coagulation occurs and fibrin forms around the platelet aggregate to initiate a repair. Okay? And then you're going to have your secondary. The secondary is responsible for stabilizing that soft clot that the primary made and maintaining the vasoconstriction. It's got intrinsic and extrinsic pathways which result in the conversion of prothrombin to thrombin. Thrombin is what is necessary for the fibrinogen to be converted to fibrin, which is what stabilizes that protein and anchors the platelet plug to the site of injury, and it prevents any further bleeding. Okay, it's activated when the cascade system of coagulation is activated by substances released at the time of injury. It depends on the type of injury to the vessel if one or both clotting pathways is followed. The sequential steps of hemostasis are found in your book in chart 55.2 on page, I believe it's 706. Okay? Coagulation factors in the cascade system are generated by liver cells, except for factor VIII. Only the von Willebrand portion is going to be circulated by the liver. It circulates in the plasma as cofactors. Your cofactor VIII is produced in many organs, including your epithelial cells and your megakaryocytes. Both activation of factor VII and activation of factor XI will prompt the cascade reaction activating your factor X. Factor X, factor III, and factor V, calcium and platelet thromboplastic factor, or PF3, activate your prothrombin activator. Okay? Prothrombin activator will convert the prothrombin to thrombin, and that's going to convert your fibrinogen to fibrin. Fibrin is going to form a loose mesh with your factor 13, causing the formation of cross links. Look at it kind of like a piece of cloth. If you could hold it like a piece of linen cloth, you can hold it up and you can see the weave. That's what this fibrin is doing. It is weaving. Okay? Cross links. They're going to convert that fibrin to a dense aggregation of fibers, okay, or your scab. Platelets and red blood cells become caught in that mesh of fibers to form that clot. Damage to tissue is going to activate your factor III, which with calcium will activate that factor VII, causing an cascade. Your factor 12 and active platelets activate your factor 9, starting the intrinsic mechanism. Okay? It's a cascade of events. One enzyme activates the following proenzyme until that mesh network is established in its functioning. A blood clot is formed and the bleeding stops. Hereditary bleeding disorders like your hemophilias are caused by deficiencies in the factors involved in that cascade. Identification of the intrinsic or the extrinsic pathway and which factor is involved is important to help these patients because of the implications of laboratory tests and medications that are needed to be ordered for these patients. Excuse me. The older adult is more vulnerable to possible problems with clotting, oxygen transport, and fighting infections, especially during periods when they're having an increased demand in oxygen. Aging changes do not usually occur with the white blood cell count or the platelet count. Okay? Anemia is usually caused by a disease process or other systems as opposed to the hematologic system in the older adult, like a GI bleed or malnutrition will be the cause. On health promotion for these people, you need to have them eat a well-balanced diet that's rich in vitamin B12 and iron and protein to supply that bone marrow with the building blocks that it needs to build the blood cells. Exercise encourages the production of blood cells and decreases the risk of coagulation disorders and cardiovascular disease. Alcohol consumption for these patients damages the hematologic system due to poor nutrition, damages to the GI tract, and damages to the liver with decreased coagulation factors and red blood cell production. Okay? The hematologic system affects every organ in the body without exception. Individuals can do a great deal to maintain and optimize the health of their hematologic system. Tracking of lab values is very important over time to determine trending and abnormalities. Okay? And this requires the nurses to perform that dreaded thing called critical thinking. Okay? Problems can range from conditions like anemia, which can be managed pretty easily. They're non-life-threatening disorders. They affect they can be fixed quite often with vitamins and a good balanced diet, or the problems can range all the way to life-threatening disorders that can affect the blood's ability to clot. You're going to need to rely on your critical thinking skills to interpret your patient's symptoms, an assessment of the findings to determine possible or potential patient diagnosis, and to consider the appropriate actions that you're going to need to take. Because that hematologic system impacts the whole body, the nurse needs to do an assessment on the whole patient. Okay? Now, assessment methods. Information that you're going to need to know about their age, their race, their gender, and ethnicity. These can affect susceptibility to some hematologic disorders, okay, like your thalassemia. Nutritional status can alter cell quality and affect clotting factors. You need to assess their iron, their protein, minerals, and vitamin deficiencies. Ask about alcohol consumption, which can impair their liver and reduce that clotting time. Ask the patient about if they're feeling tired, okay? And if they require more rest since the most common manifestations of anemia is fatigue. You'll want to ask them about this. You can also have them compare how they are doing now with how they were doing a year ago to see if their level of fatigue has changed any. Current issues or why the patient is being evaluated. It's important to determine the patient's perception of their health status. A lot of surgical procedures can affect the functioning of the hematologic system. Any diseases that involve the organs that work in the hematologic system also can result in disorders like your liver, your spleen, your bone marrow. You need to discuss with the patient wound healing, complications, see if they have any problems with bleeding, see how complex their bleeding is after surgery or after injuries. Many of the hematologic disorders are familial in pattern, so you'll need to do a good family history with them. Many risk factors associated have only a temporary effect, and they're going to subside once the risk factors are eliminated or resolved, like your dietary deficiencies, or maybe they're taking some medications that are suppressing their immune system or their bone marrow production. Okay? Others can result in permanent damage like bone marrow disease. Table 39.3 on page 791 lists drugs that can impair hematologic system. You might want to look those over. There might be a couple of questions on the test on those. Okay. Now, physical examination. You're going to do a complete physical exam, like I said before. You need to thoroughly assess the effects of the hematologic system for dysfunction. Okay? Patients who are short of breath or fatigued or exhibit poor stamina or poor mental acuity may be at risk for anemia or infection. Fever is a very serious sign that would warrant prompt attention, especially if it's a neutropenic patient. A fever is often the only observable indicator of an infection in a neutropenic patient. Okay, what are we going to look for? In the skin, for anemia, you're going to see pale or loss of pallor. Liver failure, you're going to see someone that is yellow or jaundice. Polycythemia vera, you're going to see pink or flush skin tone. With a rapid breakdown of your red blood cells, you're going to see the dark brown skin tones, okay, because that's the hemipigment coming out. Platelets or clotting derangements, you're going to see tiny petechia, purpura, or ecchymosis. Skin changes in the absence of a recent injury need to be reported immediately, and they need to have some lab analysis done, okay? On the head and neck, you want to check the gums, the lips, the tongue, and the teeth for any tenderness, any changes in saliva, any inflammation, redness, ulcerations, or bleeding. Pernicious anemia and iron deficiency anemia produce a characteristic smooth tongue texture, and there is a good picture of this in your book, and pale gums. Lymph node enlargement or tenderness is especially in the submaxillary, tonsillar, and supraclavicular regions can be seen also in these patients. You're going to check their eyes and sclera for coloring and swelling. Symptoms of the head and neck are most worrisome in patients with neutropenia because these can be an indication of infection. Yellow appearance in the sclera can indicate accumulation of bile pigment due to a rapid or excessive hemolysis or liver disease, okay? In the chest, the heart is a very sensitive indicator of abnormalities, okay? increased rate in response to infection or anemia. Your lymph nodes are going to be noted in the mediastinum or the axilla. They're going to become enlarged and tender with inflammation, with lymphoma, and other metastatic cancers. In the abdomen, you're going to see enlarged spleen and liver, and this will be a general indicator of increased blood cell destruction. Liver tenderness may be due to clotting abnormalities as well. Kidneys, you want to assess for gross or occult hematuria. It can be grossly bloody red, or it can be a dark brownish gold urine. Test for protein and blood both. Okay. Remember that your chronic kidney disease produces less natural erythropoietin, so they're often going to be anemic patients. Okay. Musculoskeletal, you're going to check their ribs and their sternum for tenderness, especially with your leukemic patients, or if you think someone has leukemia. Assess for tenderness and range of motion in their joints. Joint tenderness is often seen in your sickle cell disease. Okay, document any swelling or any joint pain. The abdomen should not be palpated if the spleen is enlarged, because like I taught you when we were doing physical assessment, an enlarged spleen is very tender and easily ruptured. Okay? Palpate the edge of the liver. If you can palpate it, it can indicate enlargement. You're going to want to observe their stools for blood, which can be indicative of a GI bleed from GI ulcers or intestinal polyps. In the central nervous system, you want to assess cranial nerves, because some of the problems are caused by specific problems, like your B12 deficiency impairs nerve function, and chronic deficiencies can cause permanent degeneration. Leukemia can also present with neurologic problems because of bleeding, infection, or tumors within that brain. Okay? Perform frequent neurologic checks and cognitive function checks on these patients. Remember to assess their social support and their finances as well, because these problems can interfere with their adherence to therapy. All right? I'm sorry, it's not moving. There we go. Labs. Okay. You need to pay attention, like I said earlier, to the chart 39-2 on page 794. This is going to give you your norms that you will be seeing on the test. A blood smear is one test. It's a rapid test that provides information on the size, the shape, and the proportions of your different blood cell types within a peripheral blood smear. Okay? Red blood cells, it depends on your gender and your ethnicity. Your count does. Increased amounts with higher elevation can be seen. So if you live in a higher elevation, you can have a higher amount of red blood cells normally. Okay? And also those that do a lot of physical training. Increased red blood cells is called polycythemia vera. It can be caused by COPD, congenital heart disease, and chronic hypoxia, and this is without having your higher elevation stuff in that consideration. Decreased red blood cells can be caused by abnormal bleeding, destruction of your red blood cells, lack of hormones and elements for cell production, and bone marrow suppression. The next one is your hemoglobin. Increased hemoglobin can be caused from dehydration and polycythemia vera. Decreased in hemoglobin can be nutritional deficiency, bleeding, anemia, or hemodilution. Okay. Your hematocrit's next. It represents the percentage of hemoglobin in a given amount of whole blood, or the concentration of hemoglobin. Okay? It is highly susceptible to fluid status changes. If the hematocrit's not reported on your lab findings, it's easily estimated by multiplying that hemoglobin value times 3. Okay? Your MCV, if it is less than 80, you're going to have microcytic red blood cells, which are too small. These will be seen in your iron deficiency anemia, people with lead poisoning, people with thalassemia, major and minor. A value greater than 98 in red blood cells is going to be macrocytic or large cells, okay? And this will occur with your liver disease, your pernicious anemia, and folic acid deficiencies, okay? Normal range is what they call normocytic, and these can be seen in people with anemia due to blood loss. So in other words, the size of the cell is normal. There's just not enough of them, and that's due to blood loss. Okay, your MCH is going to be the amount of hemoglobin in one cell. That's what that value is. Your MCHC is proportion of each cell that is occupied by hemoglobin. You can have normochromatic, hypochromatic, and hyperchromatic, and this actually is going to help you determine how red the blood is. Okay, your MCV, MCH, and MCHC are measurements used in the classifications of your anemia. Okay, the MCH and the MCHC determine whether red blood cells have a normal amount of hemoglobin. It shows in their normal colored, or their light colored, or their dark colored. So your normochromatic would be your normal colored, your hypochromatic are your light colored cells, and your dark colored are your hyperchromatic. Okay? Iron deficiency anemia is the most common cause for your hypochromatic, to where the cells are lighter. A large drop in hemoglobin level below 10, or a series of decreased levels of hemoglobin on consecutive reports may indicate anemia, and these need to be reported to your healthcare provider immediately. Okay? Reticulocyte count, it helps to determine your bone marrow function. An elevated count indicates that the red blood cells are being produced and released by the bone marrow before they're mature. Normally should only have about 2% circulating. An elevated level is desired in an anemic patient or after a hemorrhage, because it indicates that the bone marrow is responding to the problem that you're having. Okay, so you should see an elevation in reticulocyte counts after someone has had hip surgery, for instance. Okay, that's normal. If an increase is not due to an injury or a disease response, it's indicative of polycythemia vera, which is malignant overproduction of your red blood cells by the bone marrow. Okay, and we will talk about polycythemia a little more later. Platelets, you have a normal range of 150 to 400,000, 150,000 to 400,000. Okay, increased platelet counts can occur with malignant tumors, especially if there are metastatic lesions. Can happen in polycythemia vera and with splenectomy. Okay, decreased platelet counts may be idiopathic in nature, related to cancer, autoimmune disease, or as a result of a viral infection. Platelets are also called your thrombocytes. Okay, when the value is low, they are at a greater risk for bleeding. Your patient is. Values between 40,000 and 80,000, they can have a prolonged bleeding time from trauma or dental work or surgery. If the platelet count is below 20,000, it is going to be indicative of a patient that can spontaneously bleed. Hemoglobin electrophoresis identifies the abnormal forms of hemoglobin, like your hemoglobin S that's found in sickle cell disease. It differentiates your hemoglobin A, which is a normal, and your hemoglobin F, which is your fetal hemoglobin. Okay? Combs test is an antigen that is both direct and indirect. It's used for blood typing. They fight against the body's own red blood cells. These antigens do. An excessive amount can be seen with hemolytic anemia. They're common in patients with lupus and mononucleosis. An indirect Combs test is used to determine if the patient has got any antibodies against blood that they're about to receive in a blood transfusion. Okay? Serum ferritin measures the amount of free iron present in plasma and the iron levels. A decrease in your total iron binding count is indicative of iron deficiency anemia. The transfurin transports dietary iron from the intestines to storage. Your TIBC will be increased when the person is deficient in serum iron and stored iron levels. Okay? Leukocyte alkaline phosphatase, or LAP, is an enzyme produced by normal mature neutrophils. It's elevated during an episode of infection or stress. An elevated neutrophil count without an elevated LAP would be indicative of some type of leukemia going on in the patient. Normal values suggest that the patient has sufficient number of cells to support host immune defense system. Okay? Neutrophils initially detect the presence of foreign antigens and initiate that immune response cascade that we talked about a little earlier. Only the fully mature and some of the juvenile neutrophils are useful in the defense. The bone marrow will release large amounts of relatively immature cells as a compensatory mechanism to combat severe infections. Okay, the total white blood cell count increases, but the rise is due to the proliferation of juvenile cells. This is called a shift to the left, and it needs to be reported to your healthcare providers. In other words, there are too many juvenile and immature blast cells in the circulation. They are not going to be able to fight off the infection. All right? Insufficient defense can occur with bone marrow disease, immune system insufficiencies, or immunosuppressive therapy. The differential is determination of each of the 5 types of your white blood cells in 100 white blood cells. So if you want to know neutrophils, eosinophils, basophils, all of that, that is your 5 cells, and your differential tells you how many of 100 cells each one is. Okay? Your ANC is an absolute neutrophil count. White blood cells that can be utilized in the first response of the immune interactions. Okay, values greater than 1,500 indicate a normal defense. Calculate the ANC by adding your bands to your neutrophils and multiplying by the total white blood cell count. And you can figure your own ANC. A lot of labs will provide you with this number. If they do not, you'll need to know how to figure it. Okay, a decreased number of neutrophils indicates that the patient is at severe risk for infection, and without sufficient defense, they can't prevent sepsis. All right, let's talk about coagulation studies now. You got your PT, your INR, your PTT, your anti-factor XA, and your platelet aggregation. They are used for diagnosis of hematologic health problems, determine effectiveness of drug therapy, and identify risk of excessive bleeding or clotting. The longer The time values indicate insufficient clotting factor or overactivity of blood clotting inhibiting therapy. Okay? So in other words, the longer the time, the more insufficient the clotting factor is, or the medication that you're giving them to inhibit the clotting is working too well. Okay? Your PT measures how long the blood takes to clot and reflects the level of clotting factors 2, 5, 7, and 10 and how well they are functioning. Anything over 12.5 indicates prolonged clotting, and of one or more of the factors is deficient. Okay? The INR is used to maintain accuracy of the PT. It's a international normal ratio. Okay? The normal range is 0.7 to 1.8. With Coumadin or warfarin therapy, you want to maintain the range between 2 to 3, okay, regardless of what their actual PT is in seconds, okay. The PTT assesses the intrinsic clotting cascade. Your PTT is prolonged whenever any factor is deficient, like in your hemophilias or in your DIC. Okay, and liver disease can also prolong the PTT due to the vitamin K dependent factors. Okay, your preferred range is 1.5 to 2 times the normal value. Your anti-factor XA measures anti-activation factor X in the blood. It's used to monitor your heparin levels. The test results can be affected by their age, their gender, their health history, and lab techniques used in testing. Okay. Platelet aggregation is testing by mixing the patient's plasma with agonist substances. The degree of clumping is what is noted. In von Willebrand's disease, the medication like aspirin, anti-inflammatories, and psychotropics and platelet inhibitors will affect the results of this testing. Okay? Now let's talk about the diagnostics involved. You have imaging and bone marrow exams. Imaging can include your radioisotope imaging to evaluate the bone marrow sites for active blood cell formation and iron stores. The isotope is given IV about 3 hours before the procedure. They're going to be required to lay down for about an hour for this test, so you need to make sure that they're capable of doing this. And they will have no special preparation or any follow-up, no special follow-up needed for this, okay? They can use a standard x-ray to diagnose some problems like multiple myeloma, which can cause a Swiss cheese appearance on a bone x-ray, okay? Otherwise, they're going to use radioisotopes for this. Okay, bone aspiration and biopsies. We're going to talk about those next. They're both invasive procedures. They require sterile technique. Bone marrow aspiration removes a small amount of the bone marrow fluid through a needle inserted into the bone. A biopsy removes bone from the marrow bone with the marrow inside and is obtained with a visual inspection of the marrow structure, okay? Explain the procedure and reassure your patient that you're going to stay with them during the entire procedure. Make sure that you have a consent signed and witnessed for this because it is an invasive procedure. They will have a local anesthetic injection. They're going to need to be prone or lying on their in the side position with the top leg flexed and the lower leg straight out. The procedure usually lasts about 5 to 15 minutes. The specimen that they get is usually 2 to 3 milliliters of marrow. Bone marrow exams evaluates the adequacy of the marrow to develop each cell type examines the cells to ensure that the cells are normal and consistent. You want to observe for filtration of the marrow with inappropriate cells and fibrosis. Your bone marrow exam evaluates for unexplained peripheral blood cytopenias, any excessive peripheral blood cell counts. You can evaluate suspicious cells in the peripheral blood, staging and analysis of leukemia and lymphomas. They evaluate fever of unknown origin at times with this, and they can evaluate your patient's iron stores when other tests are ambiguous. And it's obtained usually from the posterior superior iliac spine of the pelvis or the sternum under local anesthesia. Now, when they're done with this, you're going to need to apply a small gauze square with mild pressure to prevent any bleeding for 24 hours. You need to tell them it needs to stay on that long. They can take a mild analgesic, which is aspirin-free, for discomfort, ice packs to help limit their bruising. You need to instruct the patient to assess the site every 2 hours for the first 24 to note any presence of active bleeding or bruising after the procedure. And they need to avoid any contact sports or activities that might result in a trauma for at least 48 hours to that site. That's the end of our first PowerPoint for this. I hope that helped you out some. Let me know if you have any questions, and I'll talk to you on the next one. Bye.